Welcome back to our last session of today and the last session of this conference. The name of the session is The Challenges to a Personalized Medicine Approach for Infectious Diseases, Lessons Learned from the COVID-19 Pandemic. With this session, we would like to get an insight on how personalized medicine approaches could be a solution for infectious diseases, and in particular in pandemic situations. We have a great moderator today with us, who is Professor Eric Solary. Eric is professor in hematology at the Paris-Saclay University. He was the scientific director of the Gustave Roussy Cancer Center from 2011 to 2020, and since 2010 presides over the scientific committee of the Foundation ARC, a cancer research dedicated charity. And Eric is also part of the ICPerMed executive committee. So Eric, the floor is yours.
Okay, thank you, Monica, for your introduction. So I am going to immediately share my screen if I can, just to show you a few slides. Can you see them? Yeah. So what we have learned during this last year of SARS-CoV-2 infection is that the majority of infected patients develop a type 1 interferon response that generates cytotoxic T cells that attack infected cells. They have minimal symptoms and recover with a protective immune response, at least for a while. But a fraction of the patients develop a very severe disease, which could be related, at least in a part of the patients, to a defective type 1 interferon response. They have a decreased number of T cells. They release a lot of cytokine and chemokine, leading to multi-organ damage that in a series of cases lead to death. What we have seen during the last year is that, again, in the majority of patients, they have an appropriate antiviral response leading to an efficient immune response, but in a minority of cases, patients release pattern recognition damage that activate a stress hematopoiesis, leading to the release of immature dysplastic hematopoietic cells, especially innate immune cells, leading to immunosuppression and the release of a lot of, again, chemokine and cytokine, increasing the lung damage. So this emergency myelopoiesis releases immature and dysplastic myeloid cells with immunosuppressive phenotype in these severe COVID-19 patients. And we observe also that the circulating level of a series of these chemokine, especially calprotectin, which is the heterodimer of two alarmins, S108 and S109, and the loss of non-classical monocytes in the blood may predict high risk of severe COVID-19. These results have been largely confirmed now, and a recent publication in Cell journal produced a large-scale single-cell transcriptome atlas, again showing that many different cells can be infected by the virus, inducing the release of toxic cytokine and chemokine, especially by monocyte and megakaryocytes, including the heterodimeric alarmins, leading to the damage I've described. So today, the question we have to address is whether there is a personalized approach of COVID-19 and whether we could predict who are the patients at high risk of severe COVID-19. We know that they are mostly males, aging patients with often comorbidities, different comorbidities. There could be a genetic predisposition. There could be also predisposing autoantibodies against interferons. So what else? So this is what we are going to discuss.